Good afternoon, everybody, and welcome to those of you that have joined us. I think we're going to get started now. I know people are joining all the time, no doubt in your lunch break. So our webinar, Developing Hospital Front Door Frailty Services. We have just about 800 people registered for this, so welcome if you're watching it later online. My name is Dr. Lara Mitchell. I'm the National Clinical Lead for Acute Care with Healthcare Improvement Scotland. I'm really excited about the next hour. We've got 4 amazing speakers lined up, and I'm just interested to learn from them about front door frailty. And by the popularity of this webinar, I know many of us are. And with the scrutiny from Scottish Government on delayed discharges, I think getting it right for older adults as they present into our hospitals is one of the key solutions to working towards this. So just a little bit of housekeeping before we get going. Because of the volume of people attending, please keep your cameras off and on mute. We've got no time for introductions today because it's so busy. If there's any problems, please contact Gemma Rahill, and that's her MS Teams chat and her email there, but hopefully you've all got no issues. Just to let you know, the webinar will be recorded and will be on our web pages following the session. So let's get straight to the agenda. First up, we've got Eleanor Byrne from the British Geriatric Society. Then we've got 2 of our teams from GRI and Lanarkshire presenting from our Focus on Frailty programme. What's really important here is the speakers are all going to run one after the other and take over, but we have a 15-minute session for Q&A at the end. So to make this valuable, if you can pop any questions in the chat box just throughout the talk, and that will help us sort of tailor which questions are coming up frequently. So just pop them in the chat box during the talks. So without further ado, I'm going to introduce Dr. Eleanor Byrne, who's a Senior Geriatric Medicine Registrar at Leicester Royal Infirmary. She was a Clinical Frailty Fellow when she did this work for the BGS. And thank you so much for joining us, Eleanor. We really appreciate you giving up your time. And we'll look forward to hearing what you've got to say.
Fabulous. Hello and welcome. Thanks again, really, to Healthcare Improvement Scotland for the opportunity to present this work. So I am Dr. Ellie Byrne, otherwise I feel like I'm being told off, and I'm at Jerry's Reg down in the East Midlands. I've also got part of my training scheme that's doing a flexible portfolio training, so time to do quality improvement work, which is where some of this is slotted in. And part of this presentation has got some contributions from Dr. Amy Armstrong, who's an emergency medicine consultant in Edinburgh. Okay, so what I'm going to briefly run through is a little bit of the survey that was set out by the British Geriatric Society kind of last autumn, who kind of began the work and realised there was a bit of a gap in the market for this. I'll touch briefly on how my fellowship role is structured before moving through those principles on setting up services and that document there on the right. And I think, as Lara's already mentioned, I think this is really topical. Our global population is ageing, it's causing a massive challenge to our healthcare systems worldwide, and the needs are becoming more complex and the demands are increasing. And by the fact you're here, it sounds like you already have recognised that, so hopefully we can do a bit of learning from each other. So just to start off with and make sure I know I'm talking to some people and not just my computer screen, hopefully there's a poll that's going to pop up, and if you could enter one word that you think kind of comes first to mind when you're thinking about your frailty service. And I think it just might be quite interesting kind of what people think of first, and we can maybe reflect on that when we get further through this webinar. But I'll just pause for a moment to let you have a bit of a think and type something in before I move on. And I hope that poll will just stay there so you can continue to pop that in. All right, I'll move the slide on, but hopefully you can still pop it in if you're still having a bit of a think about what word summarises your service the best. Okay, so how did this start? So Dr. Amy Armstrong, who I worked with this BGS project, is an emergency medicine consultant who's working in quite a novel split role with the ED and within the ED frailty service. So she's got kind of a combined role, one of the first, I think, in the country. And she was tasked with setting up a service and didn't want to reinvent the wheel, so thought she'd be sensible and ask other people what they did. And I think took a step back initially, saying that frailty and multimorbidity and complexity is a massive part of the ED take, even if that's not what kind of the TV series suggest, but in realistic terms, that is a lot of what our emergency medicine colleagues see. And knowing that increased frailty is related to increased admissions, longer inpatient stays, and increased consultations with GPs. And I think looking at recently, the annual costs to the UK are £5.8 billion for this cohort. So it's a big thing and a big issue. And recognising that there is increased harm of hospitalisation and a disproportionate effect of crowding long ED wait to our older adults, I think is important. And Getting It Right First Time, or GIRFT, has also recently published some 6 steps to better healthcare for older people. And 2 of those are very relevant to this. One of them kind of looking at frailty early and scaling what frailty is, and also having a home first mindset. So Dr. Armstrong was part of the special interest group, and there's our frailty and urgent care settings, and I hope the link has popped up for you. She used that group because it's a community of people who are doing similar work, so similar minds to ask the same questions to. And use this SIG to ask a survey, because there was a bit of a lack of practical advice about what to do in trying to start these front door frailty groups. And the plan was to try and address this with some practical advice, which I'll come on to, because we know that there's increasing difficulties in the flow and the pressures on our hospitals. And I'll come through to that shortly. Okay, so just to start with the survey. So it's a bit difficult to know from the literature which patients front door frailty teams are seeing, how they identify them, how long this process takes. And I think the impression was that it's a bit variable, but it's quite helpful to get a bit of data to back that up and inform service planning. So in an attempt to further characterise this is why the survey was sent out to the special interest group members. And in short, it was 8 questions, multiple choice and free text, and focused really on selection of front door frailty services, and also to test the water for the engagement of the SIG and how kind of receptive that group of professionals were to this coordinated approach. So I'll just briefly touch on the demographics. So there were kind of 309 respondents, and that gave 200 complete data sets. And on the left, you can see kind of the split within professionals. So the majority consultant geriatricians, but a good split throughout the MDT. And on the right, noting that there's responses from all 4 nations, majority within England, which may well map kind of the activity of front door frailty services at the time. And so then I'll move on to the first questions about kind of where frailty is identified routinely in your hospital. Identifying patients at high risk of adverse outcomes due to their inherent frailty is clearly the first step in actively managing these patients, as long as it changes something. So the aim here is that identification of frailty can help to streamline these patients to the most appropriate clinical area. And it's really great that about 75% of respondents reported that frailty screening occurs in their emergency department. Some of that may be related to the NHS England sequin, which has probably bolstered that response, which I will touch on just on the next slide, where kind of 30% of ED or same-day emergency care patients over 65 have a frailty assessment with appropriate follow-up. So just to step to one side from the survey for a minute and mention some of the things going on across the border. So this is all related to the NHS long-term plan, where kind of frailty ED services in type 1 emergency departments, my understanding is they're the ones that are open 24/7 with consultant cover and resus facilities, should be having a frailty service for 70 hours per week. It'd be to assess frailty within 30 minutes of arrival. And as I've mentioned, there's now a sequin that was started in April April 23, April 24, sorry, to run for 12 months. And that's an incentive, monetary incentive for identifying frailty properly. And NHS England have also released 2 other strategies in the last couple of months, one of which being that frail strategy that you can see on the slide. So focusing on the problem, so they suggest a few criteria that could be used to identify the right cohort, such as a LOO score, a clinical frailty scale, or a 480 score, and aiming for an SDEC by default approach, so trying to get people as a review and home, and also a fit to sit approach, so aiming for people to be chair-based rather than bed-based as standard if able. So referring, so that's making sure frailty services are accessible. They suggest an MDT for 10 hours a day, ideally 12, with this service running 7 days a week with a connection to community teams. And NHS England's assessment is making sure the frailty team have got the skills to assess, and that dedicated frailty units aren't always required, depending on the makeup of the hospital, which complements other work, which I'll mention shortly. And also that a clinical frailty scale of greater or equal to 6, those cohorts are the ones that should be getting a comprehensive geriatric assessment. Identifying needs, so the implication of finding those frailer older patients, making sure they're getting a personalised care plan, advanced care planning if needed, and ideally not being in SDEC for more than 8 hours. And then the leave at the bottom is making sure that it's all coordinated. So you've got the links to discharge planning, you can communicate to the right people, whether that's out with community teams or back to primary care, and the transport to get those people home. They also have got a little self-assessment tool as part of the frail strategy on the NHS England website. There is also a same-day strategy, which is similar but a little bit more nuanced to SDEC priorities rather than just focusing on frailty, but also quite a useful resource to have a flick through. Okay, I'll just go back to our survey briefly. The next question was looking at what tool do you use, and as we can see, the clinical frailty scale here is fairly unanimous, with 95% of places using it. And that does feel appropriate, given that it's probably the most widely recognised by non-specialists. We know it's validated and recommended by AFN, the Acute Frailty Network, and it's quite a reliable predictor of outcomes in the urgent care context, despite this not being its initial intended purpose. We know it's got good inter-rater variability. And I think the link for the app's just been posted. It is really quite quick and straightforward to use. But I think it's also probably appropriate to mention that training is needed. There is a little bit of concern about the phenotypic model of assessing frailty when people are unwell, and that can inflate acute frailty. And I'll also mention here that not all older people are frail. There are influences from where people live. So I think the focus does need to be not to discriminate on age, but focus on their need and recognise that frailty, as I've mentioned, is associated to a higher risk of adverse outcomes. So, and then how long does it take to assess frailty? I think it suggested that it was variable, and there's probably peaks right at the start. So assessments emergency at the front door and in AMU in the first 4 hours or so, and then a later peak, which I think is probably going back to in hours when different members of the MDT are working again and different teams are then completing those frailty assessments. And then moving on to kind of cohorts and criteria for referral. So I think Amy regretted this slightly, having a free text box for this question, and had 180 answers with lots of extra information. And mainly it was combinations of these factors. So over 65 for some, over 75 for some, and some were just using age alone as a criteria to their frailty service. Having a frailty syndrome or geriatric giant, or potentially a fragility fracture, fitted onto a criteria for some places. Often there was a new score, so a criteria of kind of how unwell they would be. Maybe it had to be less than 3. The clinical frailty scale was commonly used, but that could have been greater than 4 or greater than 7 for some. So again, a big spectrum in what was appropriate for their service. Care home residents, some wanted to see all that came from a care home as kind of standard, and having an estimated length of stay less than 72 hours to make sure they're seeing the people that ideally they can see and turn and get back into the community setting. And kind of some wanted a direct referral and discussion with all people. Another wanted just to make sure they didn't have a fractured hip or a reason to need to be under a different specialist before coming to their service. So the message really is there's a big spectrum, and it's a lot of different criteria that fit different hospitals and services. And as I will mention a few times, not one set criteria fits all. Okay, so just concluding that part about the survey. So frailty identification and screening probably is on the increase across a range of settings, both in the acute and community. But the challenge now is in geriatric medicine is to work out how best to deliver this frailty attuned care across the whole hospital. And what you're really asking for is kind of a cultural change, and that needs to get into the acute settings. CFS seems to be the tool of choice, but again, that's useful only if it impacts on the patient. It can help to recognise the risks of a protracted admission in that particular patient group. So I think some personal conclusions from Amy that she's handed over to me is that it was useful to see the information to inform who to see, that she's really felt that she has learned experientially whilst developing her frailty service, but is still kind of searching for what is the optimal team to make it work, that she needs a team that's ideally appropriately trained, is dynamic, and can manage frailty and complexity in ideally a very coordinated healthcare system, which I hope is what we're all striving for, but not necessarily working within currently. Okay, so I'll just move on to touching briefly on this fellowship before covering these principles. So I did a part-time 2-month fellowship within the British Geriatric Society. I was able to do that because I could rearrange childcare and start immediately. It was quite time critical to get that piece of work put together last autumn before kind of the push of the winter. It was supervised by the BGS manager, and it was a virtual working post. I think it was quite nice that kind of the concept was defined, so you had kind of a little bit of a structure, but the final piece of work really developed organically with the people that I was interviewing as part of putting that piece of work together. So within the UK, definitely within England, there's an opportunity to add a theme for training where I'm doing quality improvement, and that just offers a little bit of extra time to focus on these things that are outside the core curriculum, and opportunities to kind of incorporate those, I think, are on the up. Okay, so I'll get back to what we're talking about. This is the resource. The previous QR code or the one coming up might be a bit more effective, but I think this link's already been sent round, and I'd recommend downloading and reading the PDF. I think it's a bit easier to read. But kind of as this part-time frailty fellow, I created this, and the aim was for it to be an overview after engaging a limited number of sites with established services. I was tasked with creating a resource to support healthcare professionals who are looking to start or develop a front door frailty service. And the need for this has developed due to kind of the healthcare crisis we're seeing across our UK hospitals, with big ambulance waits, with queues to get into hospitals, alongside backdoor exit block, which could be restricted by rehabilitation or social care services. And it's recognised that identifying those with frailty and starting CJ early could divert them to the most appropriate services, for example, community-based services. So to do this, we use the very well-known research method of a BGS-X, formerly known as Twitter shout-out, to work out who are the shining lights in the world of front door frailty across all 4 nations, so I could learn who to approach and who to seek the advice from. And I did some semi-structured interviews to gather some knowledge and opinions from leaders across the MDT who are working within established services. So, on the BGS website is this document, and it's been designed to complement all of the great work that's been developed in this area already. And I'd encourage everyone to have a bit of a hunt around on the BGS Frailty Hub, that I only really found when I was in post, and I thought it was really quite useful. And we know that front door frailty has got a positive impact everywhere, that it's been implemented effectively through reducing unnecessary admissions and helping our frailer patients get home as soon as possible, ideally the same day. Effective front door services contribute to hospitals operating more effectively, reducing long waits in ED, delays in discharges, and missed opportunities that can be the ones that create those super long stay patients, which can also be associated to having poorer outcomes. And as I've already mentioned, there's no right way to do this. It's dependent on multiple factors: the hospital estate, the workforce, the local population, to name just a few. So we've produced a compendium of advice and spin it back ideally to the common themes that could be implemented in lots of different settings, rather than just collating case studies, which sometimes don't feel quite so applicable. So I'm just going to briefly run through these 5 principles for you. So number 1, prioritising the development. You can't just put a label or a sticky plaster on a service, and hope it fills the gap. You need to be able to invest time, money, enthusiasm to the process, and let there be a willingness or a culture for there to be change. You've got to start somewhere, start small, and have a vision. And focusing on patient flow alongside the data as a language to translate the impact of front door frailty services to hospital management teams can be crucial. Working out the demand of the service, ideally 12 hours a day, 7 days a week, is really important, but it also needs to be deliverable. And deliverable initially as an intervention, it can then be expanded and developed. So moving on to number 2, proving your needs. So you need to have a QI mindset with these projects, really, a collaborative approach, getting all the stakeholders around the table and continuing that throughout the process. So having regular improvement meetings throughout the development, involving kind of the people in ED, the frailty experts, the management team, but also the outreach into the community that you want to connect your service to. Involving patients in design can be quite crucial. They can often have quite a different perspective or different priority to what you maybe think you're aiming for. And having a small pilot project can often be used as a lever for change and begin the interventions or the focus on front door frailty services. There is such a variation between existing frailty services that it's really hard to collect comparable data. And all the sites I spoke to were quite interested in developing a unified data set for benchmarking, because often the audits we've got running at the moment can sit very much within ED or within acute medicine, and often acute frailty services can kind of bridge that gap. We maybe don't sit kind of completely within one of those audits that's already been running. But to develop a unified set, we'd have to make sure that we weren't then multiplying what was being inputted into other audits. Let me just go backwards. There we are. So mapping the organisation, so looking at what you've already got and complementing what's there, I think is really important. There's so much variation. You can't just create a map or a plan for every single hospital and decide that's what should happen. And the most important point, I'm going to say it again, is to make it collaborative, lining up with the other specialties, the community teams, the management teams, and finding the common dialogue so that everyone could get on the same page. So this diagram simplifies a generic process, appreciating that there needs to be variation in the approaches that is needed. And here's just some examples of some potential interventions. We'll start off there in the blue box on pre-admission. So some people call it the silver phone. I'm aware it's got lots of different names, but that can help to optimise patient care in the community service. Enable there to be kind of scheduled secondary care visits, for example, a CGA or a rapid hot clinic. And as patients with frailty are most often conveyed to hospital by ambulance, this can be a system also accessible by ambulance services. And then the patients often would kind of potentially go into ED. And identifying those with complex needs that ED doesn't have the capacity to address is a significant role of the frailty services. And the message from people I spoke to was really to push back on the 4-hour wait and to build the trust and the data to demonstrate the impact that can then have to the patient and on ED workflow by allowing a little bit more time there right at the start. There's a few different methods that sites are using to do their work in ED. So in-reach is often the first point of intervention, kind of the easiest method to start. Getting to patients early. Sites are very much recommending the advanced practitioner role. And I think it was from St George's, kind of gave me a really nice quote of a roving service can deliver SDEC as a process rather than a place, if kind of the hospital structure feels like a bit of a limiting factor. There is, however, a bit of a concern that that potentially spreads out the MDT. So having a frailty ED space, a dedicated space for this cohort, could potentially allow for more effective MDT working. Moving us around to the green box just there. So having a proof of concept project to trial a focused unit or same-day emergency care area can often be a way that these can start. There often seem to be dual purpose units for the ones that seem to be flourishing and very successful, to have an SDEC assessment area and also a bedded area for probable admission. These assessment areas are often a more suitable environment for our patients with frailty skilled staff working there. There were a lot of concerns raised by lots of sites about the lack of flow and the risk of exit block hampering the design. So I think that then needs to be a focus early on in how these designated units are designed. Taking us back up to the top, that community box, I've listed a few out of, I'm sure, many community interventions that exist and are available, but having knowledge of and connection to all of these services allows for integration and effective working for early supported discharge. And bringing us on to the final two. So identifying frailty. Prioritising this can help to find the right people where a rapid CGA can dramatically change their hospital attendance. As I've already mentioned, most people seem to be using the clinical frailty scale, and having an admission criteria to the frailty service is often needed initially to make sure it's deliverable and that you can achieve assessment of this cohort. But the aim from established sites was that as the service matures, referring teams understand the impact of a frailty team, and admission criteria can then become less rigid, if not needed at all. Concern has been raised that the CFS can take a little bit of time to embed, and there's variable completion and quality. So the emphasis here is really on the dialogue with referring teams. And finally, moving us on to the team, or the relationships that are needed. So that's within the hospital, within the frailty team, within the other hospital services, but also beyond into the community team. Making sure kind of you're building trust and knowledge of what each team can do, but it is really a two-way learning system to bridge the primary secondary care interface. And the focus for this kind of principle is to how do you empower the MDT to deliver this care? As I've mentioned, lots of established sites are really embracing the advanced clinical practitioner role. It offers service consistency away from potentially rotational doctors, and is a method to retain experienced staff in clinical roles. Don't underestimate the need for a senior decision maker near the front door. It needs to be a person with enthusiasm, but also as part of the design, you need to appreciate the on-call requirements that they may have within part of their other job role, and how that needs to be incorporated for a sustainable job plan. The aim for most sites was to develop their own dedicated frailty MDT, and that occasionally needed role blurring of therapists to allow for kind of time efficient CGA to be completed, alongside touch points throughout the day for a appropriate handover of information. So just bringing us on to concluding my bit, if that's okay. So starting somewhere and starting to do something, however small it might be, but this needs time, dedication and enthusiasm with persistence, because we're asking for a cultural change within health services to what's currently being delivered. Finding your tribe, finding your team, and identifying your supporters and early adopters who might get on a change in service provision quickly. Thank them, look after them, because teamwork makes the dream work after all, and we know that CGA is a team sport, so it's really important to make sure we are embracing the enthusiasm. And as I've mentioned, there may be person-dependent processes that are required initially to kind of bridge between the silos, bridge between the teams, and accepting that that may be part of the development process before that can then be established into part of how the service functions. So this work's potentially raised kind of more questions and scope for further work that needs to be done within this area. And as I've suggested, a national data set would enable some comparability between sites and enable comparison and to learn from each other. And it's also having a think about how we can best share resources from people that have already developed these services or have got bits established. So the British Geriatric Society has got networks and a SIG to enable that, but there's also the Future NHS collaboration platform where slightly smaller organisations can often have a bigger voice. And just to tie it up really by saying that frailty is everyone's business, and our challenge now is to work out how do we deliver frailty attuned care across the whole healthcare environment. So this work's already been presented at the British Geriatric Society, which led to a presentation in Canada at the Frailty and Elder Care meeting through Ken Rockwood, and we're in the process of writing this up as a lessons from a UK perspective for a Canadian journal. I've really been impressed by how well this has been received, so thank you very much. And hopefully we can now move on to seeing some of this practical examples of how this has been implemented.
Thank you so much, Eleanor. Big round of applause, big virtual round of applause from everybody for sharing those key 5 recommendations in setting up frailty services, always starting with identification. I've seen some hands up, but please, we're going to run all the speakers together. So post any questions in the chat box. Please do it now so we can collate them for our Q&A session at the end with all our speakers. So it gives me great pleasure to go straight on to our next speakers who are from our Focus on Frailty programme. We've got Dr. Laura Duffy, who's a consultant geriatrician at Glasgow Royal Infirmary, and Erin Walker, who's an advanced practice physiotherapist in frailty. And they're going to share some of their journey over the last 9 months. Thank you, Team GRI.
Thank you, Lara. Welcome. Thanks very much for the opportunity to share our work. As Lara mentioned, we've been a member of the HIS Focus on Frailty programme for the past 14 months or so. And hopefully over the next few slides, you'll see some of the principles that Eleanor has mentioned being demonstrated through the work we've done. So this is our drive, and we chose to focus on developing our acute frailty at the front door service through rapid identification, streamlining patients with frailty for rapid CGA, with a view to trying to reduce lengths of stay and consider those early alternatives to admissions within the MDT. So in terms of the building blocks for change, we definitely agree with Eleanor. We very much tried to put frailty on the map. As a department, we agreed to make frailty a key priority. We met with our senior leadership colleagues to discuss our work and gain their agreement again to prioritise frailty locally. I think being a member of a national piece of work definitely helped in terms of giving us some weight behind the work we were doing. We started to build those relationships with key stakeholders through some education sessions initially, and then we developed a key stakeholder group and had agreed forum for discussion set up. And again, those, as Eleanor referred to, those key regular meetings to review ongoing work and collaborate ideas. We did some early process mapping, particularly with regards to frailty identification at the front door and the process by which CGA was initiated. So we've moved through 4 key phases. Firstly, we focused on frailty identification. We chose to use the HIS frailty assessment tool. There was already an electronic version on our track care system, so that was hugely advantageous, particularly in terms of data collection. We then focused on streamlining patients identified as having frailty to an acute receiving area at the front door, a geographically defined area, and then our downstream wards. We developed a frailty assessment pro forma, which Erin, our frailty practitioner, and the specialist nurses use to gain that early key collateral information, and most importantly, identify the priorities of patients and carers promptly when they come through the front door. We're working towards developing a fully functioning frailty assessment area, and we've just started to trial some alternatives to admission options through a rapid access frailty clinic at one of our assessment and rehabilitation centres. So throughout those 4 phases, there have been 3 key themes. Firstly, developing the team. We very much recognised there was some the back door and the front door teams were disjointed somewhat. So we tried to bring those 2 teams together to enhance the flow of information and joined up working. We've very much worked on integration, and we've seen some really key relationships developing between the acute sites and our community colleagues and partners. And we've done some education with various MDT groups across the patch. So just to take you through some of the results to date. So we started our frailty identification test of change in September of last year. We identified patients with frailty using the HIS frailty assessment tool in ED and AAU. We've had really good buy-in from our colleagues down there, and hopefully some really good collaborative work being demonstrated. We saw significant improvements both in AAU in terms of identifying patients with frailty, and also in ED. We've, on the whole, maintained that performance. We've seen a dip recently, but hoping through various pieces of work to try and improve that again. So you'll see from that last slide that this is an overall percentage of those who attend being screened for frailty. So that was a massive underestimate of the patients we were screening for frailty who ended up being admitted. So we were looked in through to our AMU department. We saw that for those patients coming in who were 75 years and over, we were identifying frailty in 79% of those patients. So that was a huge improvement. We then began our test of change looking at streamlining. It's fair to say we've had varied success. We've had a lot of success in terms of pulling people to our downstream wards, less success in terms of pulling people with frailty to our specialist receiving area. And that's mainly been driven through flow and capacity challenges. But as Eleanor mentioned, you absolutely need to prove why you needed and prove your worth. And I think one key point is to not neglect the benefit of data in terms of convincing people that change is required. So when we have identified patients with frailty, we've been able to reduce the time to specialty beds when patients need admitted. We've also shown a reduction in our length of stay for older people with frailty in our downstream wards. And we've also managed to reduce readmission rates for patients with frailty, both at 30 days and also at 7 days. So it's absolutely worth getting it right. We have also developed CGA huddles. So effectively, these are MDT meetings which occur at the end of each acute receiving ward round. We started small, initially discussing 5 patients with frailty from our cohort, and we've built that up to 10 at the moment. A list of the patients to be discussed are emailed out to our community partners early in the morning. And that was a way of just trying to improve people's efficient way of working and recognise that people are strapped for time. So they just come to the meeting if there are patients from their locality due to be discussed. We've had really good relationships being built as a consequence of these huddles. We've begun to learn about each other's services and way of working, and some key relationships have been building. This is just to give you a feel for the multidisciplinary nature of the CJ huddles and those who attend. It's not meant to be a register. As I mentioned, people attend if it's appropriate for them to do so, but hopefully that just gives you a reflection of the multidisciplinary nature of these huddles. And we've absolutely seen an increase in direct discharges from our front door area as a consequence of these huddles. So I'm going to hand you over to Erin, who's just going to go over the last few slides.
So I think it's important, as we said, not to try and focus on what this actually means for the patients. We've seen from the data what changes we've made to length of stay, but we've seen for the patients that having access to a timely CGA and proactive AHP and ECAN assessment has meant that time to first assessment for patients coming through our older people's receiving area is 1.3 days, compared with 2.3 days for the patients who go directly downstream, and compared to 6.5 days if they're sent to a medical ward. We have seen, as Laura alluded to as well, we've seen increased numbers of AHP assessments, but also discharges from our older people's receiving area. We've seen the benefits of early carer and relative communication, where we're able to signpost relatives and carers to appropriate services and get key concerns documented and action taken on that at an early stage of admission. We are able to make proactive early onward referral, not only to services like social work, but also things like orthotics, podiatry, things that would, traditionally sometimes would hold up progressing onto therapy. So we're able to access those referrals at an earlier stage. We have also seen expedited home care access and equipment provision, largely due to expedited AHP assessment, but also because of links we've made with our community teams, and also the improved communication and team working, so trying to make sure that the information collect at this early stage of a patient's admission is transferred to our downstream areas to make sure that the transitions of care are smoother. One of the things that we've tried to do as part of our data set is also to collect patient case studies. So this is an example of one of them here, which demonstrates the pros of a timely CGA and AHP assessment, proactive onward referral and signposting to other services, and expedited discharge using some of our urgent care services and urgent clinics. And I'll hand you back to Laura for the last wee bit.
So I'm speaking for the team. I just asked for them for some comments regarding the past 14 months or so. And I think these were just some of the key take-home messages. It's definitely hard work, but absolutely worth it. And it's important to keep the team going in terms of just, recognising that it's worth not tiring from doing the right thing for patients. I would very much say don't neglect your data, because that can be a very useful tool when you're particularly trying to convince management. Planning absolutely is worth investing in. It's difficult to not just crack on and get going, which is what you want to do, but the planning is really important at the beginning. Build your team, work with it, but it's absolutely worth it in the end. Thank you.
Thank you so much, Laura and Erin. And, incredible data, but so powerful to hear the story of what's going on behind that and how important it is to build your team, to value each other, to work together and have that leadership and culture that enables change. So lots of questions coming into the chat box, which is what we wanted. Perfect. Keep them coming in. And if you can scroll on to the next slide. So we've got a slightly different tack here. We've got Hazel Gilmore, who's a frailty nurse consultant, who's going to present from NHS Lanarkshire and North Lanarkshire HSCP more about the frail strategy, about what's going on across the whole of Lanarkshire, which includes 3 acute sites. So thank you, Hazel.
Thanks so much for allowing me to discuss this today. So my name is Hazel Gilmore and I'm a frailty MAP or nurse consultant in Lanarkshire, and I'm here to kind of talk about the whole system approach to frailty that Lanarkshire's took. And although obviously this is a webinar about the front door services, the presentations that Laura, Ellen and Eleanor's already kind of spoke about the importance of that community services and the importance of the whole system, how it all kind of works together. So I started this role in October 2023, and part of my role was the implementation and establishment of the Frailty Network. So the Frailty Network was established in November 2023, and it's led by myself and Dr. Helen McKee, who is the Associate Medical Director for Frailty. So the Frailty Network aims was very much to enhance the care for frail patients through multidisciplinary collaboration across acute and community, creating those partnerships with health and social care teams, GPs, district nurses, but also the third sector, and also trying to encourage and engage and empower teams to improve our systems together. So it's creating those conditions for change and trying to kind of bring everyone together. So although the network's led by myself and Dr. McKee, it's made up of a multi-professional group. The network is from pharmacies to AHP to geriatricians to medics. It's a full collective of everyone coming together kind of with a similar goal, looking to improve things for the older adults. So like I had said, it is a very multi-professional, and it's a two-way street basically. So obviously there's a leadership and support, but also that amazing knowledge and skill set that these people have in these other areas, bringing that back in as well, because I have learned so much. So I was from the acute service, and I have learned so much from my community colleagues over the past few months, and I guess that's something that we're just trying to do. It's sharing that learning and sharing the impact that people are making in people's lives, and also celebrating that as well. I think as well, this is very much in its infancy. It's something quite new. So I wouldn't say we've got it perfect yet. There's still a lot of time and work it needs to put in for engagement and trying to get the right people around the table. But there definitely is a table, and frailty is definitely on the table from meetings, even when it's not fully about frailty. I think within Lanarkshire it's definitely there. It's getting spoke about. So obviously the as kind of Dr. Burns had said there about that building relationships in the workforce is so important, and that is kind of what we're trying to do here, and that's kind of what we're trying to achieve. So here's just a slide about the whole system approach, and all these pieces of work are happening across Lanarkshire just now. Obviously I won't talk about them all just because I would be here forever, but obviously it is important to recognise that the Frailty Network is not leading in all this, that these areas here are obviously led on by the teams that are on the site, and it's the people who are on the floor that's experts in these areas that are leading on them, but we're feeding into the network, and the network's trying to share that knowledge across the setting. Sometimes it's the acute and community, you think they don't impact, but obviously if you look at the active wards up here, the active wards is an initiative that's led by the physiotherapists and occupational therapists in the community and acute in Lanarkshire, and it's very much to try and reduce that deconditioning and promote physical and mental activity in the wards. And obviously we know that if people become more frail and deconditioned while they're in hospital, it'll have an impact to discharge plan, and that's something that we know. So obviously, but the discharge planning, and that has an access to services, it has an impact, because obviously now they require a higher level of care, and then also that has a knock-on effect to the carer support, because obviously now families and carers now are having to care for somebody who's maybe a bit more deconditioned and who's more vulnerable and got higher care needs. And it's already been spoke about, people who are more frail more likely to be admitted to the hospital anyway, so with falls and with delirium. So then obviously we have a higher number of people coming through an emergency department. So although sometimes we think these two don't maybe connect straight away, but actually they do connect through different routes. Then we've also got our offsite hospitals and our flow navigation centre, who are in the middle, and it's that very much our interface between the two. So it's trying to navigate our patients to the right places within the areas. So this next slide, so here's on the left hand side is just the highlighted areas for improvement, and right care, right place is very much the thing that we're trying to kind of promote throughout Lanarkshire. And in the middle here is this ongoing new ways of working, and as I previously mentioned, the flow navigation has been here for ages. However, it's now been elevated to kind of flow navigation plus, so it's to try and navigate patients not just to the GPs or ambulatory care, but it's also try to navigate to hospital home services, consultant connect, also our locality response teams. So it's having that more access, so that not all roads lead to, whether it's emergency departments or it's GPs, it's having that more of a kind of connected approach and wraparound services. Also the utilisation of virtual bed capacity and wearable technology. We've got our rehabilitation coordinators, which is a new process we're trying. Is again, it's that right place, right care, trying to get our patients to where they should be, and try and get away from that reactive approach and try and proactively guess what do we need to do if it's home with our integrated rehab teams. We've also got trying to implement the respect document in the nursing home. We've got a 12-month test of change currently happening, where we've got a geriatrician getting into a nursing home that had quite high levels of hospital admissions, and trying to have those kind of difficult conversations, realistic medicine, to say what does that person want, and it's respecting those decisions, but also having documentation that is spread throughout a truly different people. So the ambulance crew, the nurses, everyone's, the hospitals are all used to the same paperwork, so that we can try and prevent these people turning up at our front door when they don't want to be in hospital. When we've done our questionnaires with our patients, they don't want to be in hospital, and it's trying to take back what they want and make it person-centred. And none of this would have been possible without understanding our system. Myself and Helen have been trying to understand our systems, and what I would say is we've only scratched the surface, and we're going to continue doing that, and it's quite a lengthy thing, just because there's so much amazing work happening, but we're getting there. So why is this the approach that Lanarkshire has taken? So there's a strategy for preventing and managing frailty 2023 to 2028. However, it was at the tail end of 23, so I'm going to say 2024. So it was created by a multitude of professionals, again, from community, families, patient representations, community and acute representations. Created this implementation, sharing information, working together, sharing experiences, understanding what's the thing that we need to do to get things right. And it's not going to be a quick fix. It's going to be something that's going to take years to get right, but it's worth the long kind of pathway there, and it's very much getting it right for everyone, that making sure that it's person-centred, and that we're trying to integrate our services so that the person has a seamless journey throughout anything they're doing within Lanarkshire. So the implementation is obviously in the delivery of the frailty strategy, and although it's the overarching principles of everything that we're doing now in Lanarkshire, the kind of main three areas that we're trying to kind of have impact is the promoting health and wellbeing. And already it's been discussed about how the population is getting older, and it's trying to have that public message on how we get people to age, healthy ageing, and have a better wellbeing in later life, so that we can try and have that promotion of compassionate age and dementia-friendly communities. Also tackling inequalities, so having that co-design services with the older people and their families, so figuring out what's important to them and trying to have that wraparound approach again. Delivering sustainable healthcare, so again, this has got to be a long thing. It's not going to be something that's going to fix overnight, but it's trying to make it deliverable and sustainable, so that we can start off small and scale up for future, and making sure that what we're doing is impacting. And what are our challenges? So resource and staff, and obviously I can't lie, I have to put it there. So it's trying to look though at our services, instead of asking staff to do more and more and more, because that can cause burnout. It's trying to look at what they're doing and actually doing it differently. So it's looking at what they're doing and doing it differently, not just more. Our technology, it doesn't talk to each other. So it's trying to have that, it's proven some difficulty, and already mentioned the data and measurement. We want to get our data and measurement spot on, so that we can show the impact, and also if we change one thing at the left hand side, it's not causing an unintended consequence at the right hand side. But that's our challenges, but we're working together and we're working through it. Thank you.
Fantastic. Thank you so much again, Hazel, for sharing your vision, which you're realising in Lanarkshire about that PAN strategy approach. And we've got lots and lots of questions in the chat box. So we've got time for a panel now. I'm going to try and theme them out. So can you let me know, team, when we've got... Firstly, thank you to all speakers for some fantastic presentations and loads of take-home messages. Is everyone on screen now? So all the speakers, and Helen, welcome to you. Helen, do you want to introduce yourself? Because I think you're joining the panel.
It's bad time now, there's a call. Hi, yes, nice to see you, Lara, and the rest of the speakers. It's been really, really interesting, and I've been scribbling notes down, so there's lots of learnings we had from other sites. I'm Helen McKee. I've been working with Hazel as part of the frailty team on the frailty network, but obviously the bigger bit of work around the frailty strategy, which she's just presented on, so happy to take any questions around that.
Brilliant. Okay, so some of the things that are coming up initially are about what's the makeup of your frailty team, and so I don't know, Laura, do you want to speak to that, about who makes up your frailty team? And then Erin, if you could come in about what qualifications you have. People are really interested in, you know, what skill set you need and how you put that together. So Laura, do you want to address that?
Yeah, sure. I think the key take-home message is everybody's welcome. I think it just to be so broadly multidisciplinary. I suppose on site, the on a day-to-day basis, we've got obviously medics, nursing staff, we've got HP staff, we've got a frailty practitioner on site, and then we kind of link in terms of the CGA huddles, we link in with frailty practitioners in the community, and they in turn link in with the rehab teams. We've got some links with our assessment and rehabilitation centre colleagues in terms of rapid access clinic slots. We're linking with social work. We've got pharmacy representation at that CGA huddle, our discharge coordinators, psychiatry, who've been a real help actually in terms of our old age psychiatry colleagues. So lots of these people are often able to give us the context of the patient we're seeing in front of us, particularly the information that we're able to glean from them in terms of what's been happening with the patients in the community, which has been really invaluable. So to be honest though, anybody who is interested in older people with frailty is very welcome.
And Laura, did you have any additional community services to support this, or how did that happen, these community virtual huddles?
Yeah, so we've not had any additional resource or support. It was really about reaching out and linking in with our teams and partners and just trying to build those relationships. I mean, in time, we very much want to develop the community services, and certainly with regard to alternatives to admission. But we've not had any additional resource to date.
Great. Okay, that's great, Laura. And Erin, do you want to come in about, there's a number of questions about AHPs, about what skill set you need, how do you get additional resources? Is it reworking what you do, given the financial climate?
Yeah, so I'm obviously in post as an advanced frailty practitioner here in NHS GGC, and there are a number of us now, mainly based in community, but there are a few of us based in acute sites as well. In terms of qualifications, most of us are experienced AHP, like OTs, physios, nurses, and they are working towards trying to pull together an MSc qualification for us. So there's currently 4 MSc modules that we're required to go through to be signed off as an advanced frailty practitioner. And we're at all slightly different stages in that process. In terms of resources, we are probably not as well as staffed as we'd like to be in terms of our frailty assessment area. At GRI, we're slightly different in that we already had an existing front door team that were already up and running. So this is kind of in addition to that team. I think it goes without saying that we'd all like more than what we currently have. But that's something that we're continuing to look at, trying to prove. And we're trying to do what we can with the staff that we have and show that has a positive impact, which I think we are doing, which will hopefully then lead to, maybe more resources coming through time.
Great, thank you. And Laura, one other question that's come in the chat box is interested in the age 75 cutoff. It seems older than others. Just can you talk to us about that?
Yeah, I think you're right. So we're trying to screen patients who are 65 years and over in care homes and 75 years and over otherwise. I think yeah, absolutely. But there will no doubt be people with frailty who are, 71 and younger. So I think it's a starting point, but we recognise it's got its deficits. There's no doubt about that.
Yeah, and there's something to do with resources as well, isn't it?
Yeah.
And your job, what Eleanor talked about, the geography of a hospital and how many beds you have, etc.
And as Eleanor alluded to, you need to be selective initially, recognising the disadvantages of that, but just to get you up and running. So yeah, I think hopefully we would aim to be broader in terms of our catchment.
Great, thank you, Erin and Laura. So Helen, can I move on to ask you a couple of questions? There's some interest about where the out of hours, I've got questions for you as well, Hazel, but Helen, where do out of hours services sit within the systems? And do you have a single point of contact in localities?
So our FNC is developing, we're trying to expand on it. That's the that's a central point of contact from outside for all referrals, where there's a set of staff who are from various backgrounds, but have experience of answering, of trying to triage and work out where to send patients on, but they're not clinicians. And what we're trying to do is bolster up with clinician input, learn from the Tayside model. So ED teams are now enriching. We're looking how we can enrich, and juggling the sessions we have. Is that going to be effective use of our time? Probably is, from some tests we've done recently. The localities, there's a few different. We don't have a central point of contact for localities yet, but we have locality response teams in the north and south of Lanarkshire, which are a work in progress. But that we see that as a really good opportunity for trying to either redirect admissions or discharge patients early, but knowing they've got that wraparound support that's going to prevent a readmission and keep them safe at home. Out of hours, that's a work in progress. Hazel, what would you say around out of hours? We're not there yet.
So out of hours is a work in process basically. So but the interface division that's kind of been newly established as well is linking in with out hours to see if we can have links there, and then the out hours director is kind of involved in the interface work as well. So we're very aware of the out hours impact and the impact it can have on ED, especially because there's that less people about during the day. So it's all kind of still in the process just now.
Great, thank you. There's a couple of things coming up about nutrition. Do you do nutritional screening? What do you use? What are your interventions? Hazel, can you your frailty teams? Do you have what? Can you just talk to that?
Yeah, so in regards to nutrition, I've been in contact with a couple of the dietitians within Lanarkshire to see what they think, because one of the main things was the off-site hospitals and the also there's for the Scottish hip fracture, there's obviously people get the insured drinks if they obviously break their hip. However, it was something that we're looking at. Is it a case that people should get nutritional supplements if they're scoring on a frailty score and they're requiring that kind of long time rehabilitation? So but there's not any nutritional just the normal if they're scoring on the weights, and obviously if they're requiring a dietitian, that's the kind of only thing we've got just now, but we don't have any full nutritional supplement standards or guidelines just now. However, the strategy was created with dietitians also in the group.
Great, thank you. The other thing that's coming up is CGA. So I might bring you.
Oh, Larry, you're on mute just now, sorry.
Larry, we can't hear you, I don't think.
Hi guys, I'll just step in until Lara's able to rejoin with sound. Scott Hamilton, Improvement Advisor within the acute care team here at Healthcare Improvement Scotland. I think we're moving on to just talking a little bit more in depth about CGA. I do have the questions in front of me, and Laura, could you just tell us about the part maybe SAS could play in initiation of CGA, and as well within the capability of advanced paramedics, and they're often dispatched to parents who fall, and that was from Monica Thompson.
Yep, so absolutely. So I think obviously linking in with our SAS colleagues is going to be a key component. We've maybe done less of that on this site. Then I don't know if the Lanarkshire team maybe have a bit to say about that. I think you've done a bit more work than us already around that.
Yeah, we're trying to build relationships there and use that expertise. They're part of the FNC centre, the paramedics there who are very specially able to go out and try and avoid admissions, give advice around frail or older people, and start some sort of CGA as part of the next step with FSE plus work and virtual wards, whatever we want to call it. We're trying to create more of a relationship around the SAS teams and ourselves, and that joint approach, because this is all new to them. So is that having that consultant and immediate consultant advice if you need it, to help work together on that, but also creating the right pathways so that they can access that support, but also building their expertise. So probably a bit more ahead of game in other areas, but also a work in progress. There's quite a lot of appetite though there, I think, to because obviously, like paramedics D&D do deal with a lot of people that they probably feel they could just about manage at home, but they feel that on paper they need to convey them to get assessed in ED, and so looking at how we can help them with that safely and the governance around that to help try and maintain people at home, I think is probably going to be more rewarding for them from a job satisfaction point of view, as well as obviously help with our pathways.
I am back. Thank you, Helen. There's been a couple of questions about, core components of CGA. Does anyone have any paperwork they can share? And I know the BGS were actually pulling that together. I don't know how far to completion that is, but Eleanor, do you want to come in there?
Yeah, I know that we managed to pull a few examples from a few places. So I think I had a few from Cardiff and maybe from the South Coast that were meant to be part of the piece of work we produced. But I think they're trying to get that together on the Frailty Hub. I'm not quite sure if that's got to being available yet, but I can certainly chase that if it's not.
Lanarkshire and GRI, is there anything that you can share?
So we've done some work around a frailty assessment performed, which is effectively, key components of CGA, gathering key information regarding key components. I think we were just very keen, I suppose, to make it not a tick list exercise, and ensure that it's clear that CGA is a process and not a tick box exercise. I think that's the risk of some of these performers. So we very much regard our performers an information gathering exercise in order to inform CGA.
Mm-hmm. I've just seen a comment from our frailty lead who's said so true, and it loses that creative where we're molded and person-centered if it's just a tick box. So thank you for that.
You end up with a bit of duplication, and we also agree there that you don't need to do everything for every older person all over again.
Absolutely.
So some of the things that are happening in the community, you don't need every discipline to be intervening, because they've 99% of the time already seen a dietitian. Maybe a bit facetious, but we need to be clever with our time and our resource, don't we? So
absolutely.
if you perform a job and it can take that away, so we are kind of mindful of that, especially with our locality response teams, which we're trying to grow, but we don't have the scope for them to do everything for every patient. So it's just being savvy, but that also involves good information sharing between different disciplines, isn't it? So trying to get in amongst that.
Great, thank you. Wise words from the panel. And Eleanor, I'd like to ask you, there's a couple of questions in there about smaller health boards and remote and rural, and I think we really need to pick up on that, because I'm interested about what you said, that it needs to be an area but not necessarily a frailty unit, and the evidence, because we know the evidence is towards co-location rather than roving teams. So have you got any top tips for remote, rural, smaller health boards?
From the teams I spoke to, I think that was more kind of the Wales-based teams, where their setup kind of before this maybe became on the agenda was a bit more community-based and having stuff that was already kind of out in the community just because of the geography there, and that it goes kind of back to the geography of the hospital and what that easily adapts to. So some kind of smaller health boards that were able, there's one that's their frailty unit is located in a community hospital rather than being in the main hospital, or having kind of separate areas within ED and having just a dedicated, very brief assessment area before patients could be moved. But I think as kind of we've all been talking through, it's very much kind of what can be can be suited to the environment that you already have, and accepting what your population base is, and that is very variable across all 4 nations from the conversations I was having.
Great, thank you. That's actually great to pick up on that, and maybe we can connect some of our remote and rural colleagues with colleagues in Wales. So the other thing I would just like to ask about is that integration piece. So there's a couple of questions in there. How is the CFS shared between teams? Has anybody got any tips that they can give to us? Because this is a thing that comes up all the time about how we can integrate and make the most of our resources. Hazel, do you want to talk to that?
Yeah, so it's a challenge that we're facing as well just now, to be honest, because our electronic systems don't talk to each other, and it would be lovely if they did. But one of the things that we're thinking about trying to get more promoted is that the coding on discharge letters. So trying to get that coding right so that frailty is a past medical history and it's getting coded as such. So then when there's like when the person gets discharged, then obviously the GP has that note, and then vice versa, the district nurses, they all have that kind of same information. So that's something that we're working on. And again, in an ideal world, we could just get all new technology that was the same system, but I don't see that happening anytime soon. But so that's kind of an interim part that we're trying to do, just so that they have that more communication throughout the system. Helen, do you have anything else you want to add to that?
Yeah, I think like screening is so important, isn't it? And so just when we are the national climate resource, like trying to target the people that need us, but also with strategy work, we are also trying to do the healthy aging a bit before. So it's trying to work out where we're at in Lanarkshire. We don't know where we're at. We don't really. You think you've got a feel of frailty, but actually trying to get in amongst that's very hard. So the work you're doing with district nurses and that kind of education sharing outside the acute sites, but even within acute sites, in care elderly, we're good ED teams. They struggle with that triaging, and so it's just trying to, I think it's been said in a few presentations, but try to get key people that are enthusiastic to try and drive that change in the community and acute sites, and just make that screening more commonplace. And like what you're doing with the district nurses, that's key, and just starting in small groups and hoping that they will then run with that.
Great, thank you. I'm aware. Thank you so much. So big round of applause. I've lost my ability to do that now on this new Teams, but I am giving you all a big round of applause. Thank you all for your amazing talks, sharing the journey of your services. Eleanor, thank you so much for sharing your BGS work, and best of luck with your maternity leave from all of us. Everybody else, thank you for joining. We'd really appreciate your evaluation. The link is here. Please do fill it in, and please give us suggestions of other areas you'd like us to cover, aware we've covered so much in such a short time. There's a few other people who've said, Una said she would share a link with what's going on in Edinburgh. If we can get those together, we'll collate everything. We'll collate the links that Eleanor shared as well. And try and get it in the one place for you. Thanks also for the team at HIS for their excellent behind the screens, getting everything together. It wouldn't run without them. So big round of applause to the team there. Just to highlight our next Frailty Learning System webinar, by the way, there's over 1,000 of you connected across Scotland in the learning webinar, which is amazing. It's doubled within sort of 8-9 months. So just keep connected, keep sharing that knowledge. The next webinar is on the 3rd of October, and you can register there. So thanks again, and I hope you all feel inspired to start small, start somewhere, and keep that vision. Have a great afternoon, everybody.